Today we'll talk about the tumors of the bone. We'll start with the osteoma. As you can see from the name, it is a benign tumor of the bone. So it is a benign tumor of the bone, and its most common location is the facial bones, that is the bones of the face. You can clearly see in the picture, this is an osteoma. So most common location is facial bones. All right, then really important association of osteoma is with Gardner syndrome. So what is Gardner syndrome? It is a syndrome composed of three things. First is your FAP, that is familial adenomatous polyposis. Then we get your fibromatosis in the retroperitoneum. First was your FAP, then is retroperitoneal fibromatosis in retroperitoneum. And what is fibromatosis? It is a non-neoplastic proliferation of fibroblasts. It locally destroys the tissue where it is growing. So fibromatosis in retroperitoneum. And then lastly, the tumor we're discussing right now, osteomas of facial bones. Third thing is osteoma of facial bones. So we are done with osteoma, benign tumor, most common location facial bone, and it is associated with your Gardner syndrome. What all are involved in Gardner syndrome? Your FAP, familial adenomatous polyposis, fibromatosis in retroperitoneum, and osteomas of facial bones. Okay, now let's move on to your osteoid osteoma. We have osteoid osteoma. So what's this? It is also a benign tumor, but it is a benign tumor of your osteoblasts. So you have these two types of cells in your bone, that is your osteoblasts, which actually form the osteoid, which gets mineralized to form the bone, and there are osteoclasts which resolve the bone. So osteoid osteoma is your benign tumor of osteoblasts. Right. Now I have already told you osteoblasts produce osteoid. Now when this tumorous osteoid is formed, there is reactive bone growth surrounding this osteoid. So it has kind of this rim of reactive bone around it, with a rim of reactive bone surrounding it. Okay. Now it usually occurs in the younger age group, and it is more common in males. So we'll write males more than females. It is more common in males and presents in the younger adults. Okay, that is about less than 25 years of age. Okay, and the location which are really associated with osteoid osteoma are your shafts. You have your epiphysis, metaphysis and diaphysis in your bones, and within the diaphysis you have this thick compact cortex. So this cortex of long bones is where these mostly occur. So it arises in cortex of long bones. Arises in cortex of long bones. Okay. Now these present with pain. But a really important thing is that this pain resolves when you take an NSAID. That is resolves with your NSAID, like let's say it resolves with aspirin. Okay. And on imaging it presents as a bony mass which is less than 2 centimeters and has a radiolucent core, and I'll tell you why. So bony mass less than 2 centimeters and a radiolucent core. Now in this picture, can you see this tumor? So this thing right here is your osteoid osteoma. So can you see this reactive bone around this radiolucent core? So why is this core radiolucent? You see, this osteoid osteoma is a tumor of these osteoblasts. These osteoblasts produce osteoid. This osteoid is a matrix. When it gets mineralized with your calcium and phosphorus, then it forms your bone, what you call bone. The matrix, when mineralized, forms bones. But in this center, in the center of this tumor, the osteoid is present, the matrix. It is not really bone, it's just matrix, so it presents as radiolucent, whereas surrounding this radiolucent core you can see real bone which is radio opaque. Okay, now let's then talk a little about your osteoblastoma, because the presentation of osteoblastoma is very similar to your osteoid osteoma. So your, let's take a different color here. Okay, your osteoblastoma also has similar presentation. Okay, but what's the difference? The difference is that in osteoblastoma the masses formed are larger, so it is larger. The osteoid osteoma was less than 2 centimeters. This is more than 2 centimeters. Now, what was the site for your osteoid osteoma? The cortex of long bones. But for osteoblastoma it is vertebrae. It arises, I'll just write site is vertebrae. So your osteoblastoma presents mostly in your vertebrae. So it is larger than osteoid osteoma. It presents like it forms in the vertebrae, and it does not respond to aspirin. So the bone pain is not relieved on aspirin. Alright, this is how you can differentiate between your osteoid osteoma and your osteoblastoma. Then moving on to osteochondroma, and from the name you can see it has a cartilaginous component. Osteochondroma. Okay, so what is osteochondroma? It is tumor of bone with an overlying cartilage cap. Tumor of bone plus overlying cartilage cap. So this osteo is for your bone and your chondroma is for your, because it has a cartilaginous cap, and it has the word oma. which shows that it is a benign tumor, and it so happens that it is the most common benign tumor of the bone. Okay, now where does this arise? So you see, it has this cartilaginous component in it. When we talk about these long bones, where do you get cartilage? You have a cartilaginous growth plate in the metaphysis. So that is where this tumor arises from. This tumor is a lateral projection of growth plate, your metaphyseal growth plate. So it arises from lateral projection of your metaphyseal plate. And the bone that is this growth, this bone is continuous with your marrow space. This you should remember. Okay, now let's come to this X-ray. This here is the diaphysis of the bone, then you have your epiphysis, and between these you get your metaphysis, which is cartilage, which has your cartilaginous growth plate. Normally it should have been like this, but you got this lateral projection of cartilage. Now this bone formed around here has a marrow cavity which is continuous with the marrow cavity of this bone. Okay, so this is your osteochondroma. Moving on to your osteosarcoma. Now from the name you can like see that this is a malignant tumor. Until now we have talked about benign tumors. This one is your first malignant, osteosarcoma. Okay, so you had your osteoid osteoma, which was the benign tumor of osteoblasts. This one is malignant tumor of osteoblasts. Malignant tumor of osteoblasts. There are some characteristic X-ray features which we'll talk about, but first let's talk about the incidence. It most commonly occurs in teenagers and less commonly in elderly. So there are these two ages where this is found, in teenagers and elderly, but mostly in teenagers. There are certain risk factors associated, which include your retinoblastoma, familial retinoblastoma, which is associated with increased incidence in teenagers, and other risk factors include Paget's disease and radiation. These risk factors are associated with increased incidence in elderly. Okay. Now, how does this tumor present? It presents as pathologic fracture. There is increased tendency of the bone to break. I'll tell you why. It presents as pathologic fracture, bone pain, and swelling. Now, why is there tendency of the bone to break easily. The process of bone formation is by your osteoblast. Actually, there is this, the bone is dynamic thing. It is formed, it is laid down by our osteoblasts and resolved by osteoclasts at every moment. So the bone is actually the result of this harmony between your osteoblasts, that is your bone formation, and osteoclasts, that is your bone resorption. If either of them is affected, it will lead to weaker bone formation and which will break easily. There are these two characteristic X-ray features which we'll see. These are, you see here, you in this picture, do you see this sunburst appearance? This is what is sunburst appearance. And when this tumor grows, it pushes your periosteum. You know, this bone is lined by periosteum. When this tumor grows, it removes this periosteum from the bone. This is the bone and this periosteum got removed. So the triangle you get here is known as Codman triangle. Now these two appearances are very highly associated with osteosarcoma. Now because it is a malignant proliferation, when you get a bone biopsy, you'll see pleomorphic cells, and of course these cells will produce osteoid because this tumor is malignant proliferation of osteoblasts which lay down your osteoid. So this completes our osteosarcoma. Now moving on to your giant cell tumor of the bone. Next is giant cell tumor. What do you see in this? This tumor is comprised of multinucleated giant cells and stromal cells. Comprised of multinucleated giant cells and stromal cells, and it occurs in young adults. And the site of its occurrence is it arises in the epiphysis of long bones. So epiphysis of long bones, and you know what epiphysis is. And where does it most commonly arise? It arises in the distal femur or proximal tibia. So we'll write most commonly in distal femur or proximal tibia, which is the region of your knee. Okay. Now there is this characteristic X-ray finding in giant cell tumor which is called soap bubble appearance. So you get your soap bubble appearance in giant cell tumor, which is due to reactive bone formation surrounding the tumor cells. Then this tumor is aggressive and it can recur, so it recurs. Then lastly we'll talk about your Ewing sarcoma. So this will be our last topic. The Ewing sarcoma is malignant proliferation of these poorly differentiated cells which are derived from your neuroectoderm. So we'll write it is malignant tumor. So malignant proliferation of poorly differentiated cells, of your poorly differentiated cells, which are derived from your neuroectoderm. This you should remember. Okay. So where does it occur? It occurs in the diaphyses of long bones. It arises in the diaphysis, that is the shaft of long bones. More common in males than females, and it presents in children less than 15 years of age. Now when you x-ray this tumor, you get a characteristic onion peel appearance. Onion peel appearance on x-ray, or onion peel appearance, right? And when you biopsy this tumor, you see these small round blue cells. Can you see in this picture these small round blue cells all over here? Do they remind you of lymphocytes? Right, they remind you of lymphocytes. So these are small round blue cells that resemble lymphocytes. So when you biopsy them, you can confuse them with lymphoma or your chronic osteomyelitis, because in lymphoma you'll get these lymphocytes like cells. Then in chronic osteomyelitis, because it is chronic inflammation, you again get your lymphocytes. So how will you differentiate it from your lymphoma or chronic osteomyelitis? Because of its characteristic T1122 translocation. Okay. Now it often metastasizes, but this tumor responds very well to chemotherapy. And that will be all. Thank you.